progetto CoMPaSS-NMD cerca di rispondere a una domanda fondamentale. Quali sono le basi genetiche, quindi le variazioni all'interno della molecola del DNA che ognuno di noi porta, che possono spiegare perché e come la malattia si sviluppa? Sostanzialmente questa è la grande domanda. Questo progetto ha delle caratteristiche uniche, direi, perché vogliamo sfruttare appunto differenti gruppi di dati, quindi useremo dati che vengono dallo studio del DNA di pazienti con malattie neuromuscolari, dati che provengono dallo studio di risonanza magnetica, dati che provengono dagli studi istologici, e tutto questo dovrebbe permettere di costituire una metodologia che permetta di analizzare questi dati in modo da trovare collegamenti che sono nascosti. L'intelligenza artificiale ha questo scopo, la mente umana ha una capacità limitata di acquisire i dati e l'intelligenza artificiale cerca di aiutare il clinico a capire i vari contenuti all'interno dei nostri dataset. Ho tantissimi dati, uso uno strumento che mi permette di capirci di più. Non delego la mia capacità di discernimento, ma di sicuro se qualche cosa verrà scoperto potrà essere utile perché lo potrò aggiungere al mio bagaglio da professionista. E ovviamente speriamo di aumentare la capacità di far diagnosi.
Good afternoon, Rossella Tupler, and I am the project coordinator. I am welcoming everybody because this is the first webinar of the series trying to convey what are the basis of CoMPaSS-NMD, a tool that has been created for patients and specialists, people involved also in the care of the patient. Something that we want really to become a tool for daily work on neuromuscular disorder. This is the title of our project that was funded by the European Union. What is the scope of this project? The scope is trying to use a tool, which is artificial intelligence, in order and make artificial intelligence to serve research and understanding on neuromuscular disorder. There are other tools that have been created because there are AI-guided robots that can help patients. There is a connection and AI can be used in telemedicine. There is the possibility of understanding how much the patient move. And also there is the possibility of considering potential adverse effect. What we are doing in CoMPaSS is trying to improve diagnosis. The project is supported by European Union project Horizon Europe. And what we want is to target hereditary neuromuscular disorder, and we want to create systems based on artificial intelligence that can group patients in the best way, not only for diagnosis, but also in order to understand how disease progresses and if we can have the best care for those people. This is really what we call personalized medicine. And the beauty of what I consider the beauty of this project is that we are really putting together different expertise from very good scientists and technologists. what we want. First, we want to generate a robust and reliable data sets. What does it mean? Data are important, but data must be collected in a very precise way. And this is one of our goals. Then we want to integrate different data. So we start from the clinical observation, and then we want to integrate with MRI, which is imaging, and then histology and genetics, data from the DNA. And we are collecting this in the atlas, which is called CoMPaSS-NMD, which is the first repository with this type of data collected in the best way. The final goal is to improve diagnosis, but also to create tools to help clinicians in working better and more precisely. Where we started from a very, very, very long journey. So there is not only the journey of patients that are looking for a proper diagnosis. What we really have learned in studying neuromuscular disorders from over 30 years is that there are many differences, and especially it is often difficult to make a precise diagnosis. 60% of patients do not have a precise diagnosis, and this has consequences for people, for the system, to understand what is going on, to try to also to intervene and create a better condition. What does artificial intelligence do? It helps in elaborating complex data. It is not leading to a simplification, but really trying to understand something that might be hidden, that we do not understand with our experience at this moment. So artificial intelligence is an instrument, a tool to go forward, to have better knowledge, to improve our knowledge. And the study is composed by a retrospective study that we analyze, and this is has been already done, data that have been collected in previous studies to generate algorithms, so mathematical models, that can be tested then, whose quality can be tested in the prospective study that started more recently. And we will collect 500 patients affected by hereditary neuromuscular disorder, and each patient will have DNA analyzed, MRI, a muscle biopsy and the histology, and a precise clinical description. We also define descriptors. So we have really developed important tools, and CoMPaSS will put this all together in order to ameliorate our capacity to stratify patients. Who is going to benefit from this? Patients, of course, specialists, which will know more, pharmaceutical companies, if they want to develop new therapies, and in general, the scientific community. More important, we want to convince policymakers how important are neuromuscular disorders and which is the best way for care. And this is the description of all the partners. We have a third level of clinical centers in France, Germany, Finland, United Kingdom, and Italy. Then we have a computational center in Poland, and then a biotech company who will take care, SIGAT in Germany, which will take care of sequencing, and we have a group in Spain, Tecnalia, who is going to take care of the ethical aspect, and then we will have the atlas is developed by Fincons in Switzerland. So, and also DBL is taking care of our communication, which is very important. Of course, we want to get the best from our project, And this is the QR code if you want to participate to our prospective studies. And I want to thank everybody. Thank you very much. Now I am pleased, because after this introduction, I am pleased to introduce Professor Santorelli, who will start to pave our way in order to understand how to bridge our knowledge toward the care in FSHD. Please, Filippo.
Thank you, Rossella. Good evening to everybody. It's a pleasure to be here, and it's a pleasure to meet you, although virtually. You are in the center of our talk because what we discussed today is how to improve the diagnostic journey for each patient, each individual patient with neuromuscular disease. Overall, globally, worldwide, there are 350 million, more or less, patients affected by rare disease. Rare disorders, rare diseases are medical conditions that affect individually a small number of people. In the United States, they are typically defined as fewer than 200,000, while in Europe, rare diseases are considered those are fewer than 1 in 2,000 people. Although rare at a single level, collectively they represent a huge number of individuals. For example, if you consider the large number of patients affected by rare diseases in Europe, they count for about 27, 30 million people, more or less the size of a country like Poland. While the number of patients and the number of rare diseases is increasing, as well as the gene discovery is advancing, multiple description in the literature are not faced by a larger number, increase in number of orphan drugs designed to limit, halting, or fight this number of rare conditions. So why we have more disease rare in human and less drugs? Mostly this is because we need to understand the mechanism behind a gene associated with a rare condition, or to develop disease models, or even to understand better the clinical presentation of a specific rare disease. This is true for all rare conditions and mostly is important for neuromuscular conditions. So the major limitation, one of the major limitations in combining the met need for patients and developing in clinical care commercial drugs is related to limited understanding of the phenotype, absence of natural history studies, and developing tools that are harmonized between different clinical centers. So we have facing, for example, a condition like we have a patient with a very specific scapular winging and hypertrophy of the upper trunk muscles, but where the lack of harmonization, the lack of similar wording in the description of the patient may limit the understanding of the clinical condition and promote different gene testing that are partially associated with the real presentation of the patient. Like in this case, you have a single gentleman who has a diagnosis according to this test of a facioscapular humeral muscular dystrophy, Whereas the same gentleman may receive a diagnosis of Emery-Dreifuss muscular dystrophy according to these other tests. So there is a sort of imbalance for what we have in the patient and what the genetics says. And what we have described in the patient at the phenotypic type level and what is the real disease condition. Today we will try to understand few concepts, a few bullets on neuromuscular diseases, what kind of tests are necessary to reach a diagnosis, and also to try to discover resources to support patients while going through a diagnostic journey. The neuromuscular road, the neuromuscular, the motor road is a road with multiple stops, just in simple words. Multiple stops, like in the spinal cord, where you have in the anterior horn of the spinal cord a condition like spinal muscular atrophy, or in the axonal terminals on the neuromuscular junction, where you have, for example, conditions like congenital myasthenias, or in the peripheral nerves, where you have conditions like Charcot-Marie-Tooth, or in the muscle fibers, where you have conditions like muscular dystrophies. So different stops into the motor roads may give rise to different disease status. And this makes a sort of conundrum, difficulties in reaching a diagnosis because of the large clinical heterogeneity, single phenotype, single set of clinical manifestation can be associated with many genes. And phenotypic pleiotropy, a single gene may be associated with multiple phenotypes and multiple combination of phenotypes in syndromic status. Overall, there are about 500,000 people suffering from neuromuscular diseases that are grouped into 16 categories with more than 600 causative genes. But this is just a partial view because about half, 40% of our patients do not have a certain diagnosis. So there is still a number of other not identified diagnoses. 30% of our patients are lacking a autonomous life, dependent from others, from a wheelchair, from a caregiver, and the cost of their assistance is extremely high. So having a neuromuscular diagnosis is also economic cost for the patient, for the caregiver, for the family, and for the society. So if we have a large audience of people affected by these conditions that are considered rare, so we should consider that the numbers are not only related to the patient, but also the family members and the caregivers who usually have to leave their job or care of their family relatives, and they miss opportunities, and they also represent a cost for society. So whatever we do in facilitating the regional diagnosis, improving the care of the patient, identifying new drugs is a way to save money in this way. The number of neuromuscular disorders is extremely high, as I said, and they span from congenital myasthenia to congenital myopathies to Charcot-Marie-Tooth, from adult onset, from juvenile or infantile onset to other disorders affecting the limb-girdle muscular dystrophy, both inherited in autosomal dominant and autosomal recessive form. What does it mean to get a neuromuscular diagnosis, the neuromuscular disease as a potential diagnosis? Well, having a diagnosis means that there are different parts of your body that are weak or get atrophic, and most common forms are the one affecting young boys, like Duchenne muscular dystrophy, but there are multiple forms, and differences are based on what age the individual is affected, what age when the muscle weakness appears, and also depends how severe is the disease and which muscle is affected, and the progression. Some muscle may progress more rapidly, other may have some stable conditions. Some type of muscular dystrophy may affect only men, like the X-linked Duchenne muscular dystrophy. Some individual may experience different severity of their condition, also may have only mild symptoms accelerated by specific condition like stress or like exercise. And some people may have more severe muscle weakness, so as severe as the level that they had to use the wheelchair, or they have a limited life expectancy. Here I will try to present some very brief data on paradigmatic forms of muscular dystrophy. This is the most frequent, the most common, the better studied, and the one that receive more attention in research laboratories and from pharmaceutical companies. But it's also a paradigmatic form for other kinds of muscular dystrophy. Duchenne muscular dystrophy affects boys. Usually children are completely normal at birth, then they start developing weakness, and they lose the ability to walk independently by around age 12. Some of them may lose before that age the ability to walk independently, and they are confined to a wheelchair. Major comorbidities are related to respiratory muscle distress and weakness, and heart problems. So the cardiac muscle and the respiratory muscle, together with the problems related to the bones and to the dorsal muscle, may represent important comorbidities in patients with muscular dystrophy. In adults, juvenile period, you have more commonly limb-girdle muscular dystrophy that are a group of conditions, both dominant or recessive in their pattern of inheritance, characterized by evidence at the neurophysiology level of impaired muscle function. Laboratory tests show elevated CK levels, and usually the onset affect upper limb and lower limb shoulder muscle, geared muscles. So the hip and the shoulder can be affected more profoundly, but also other muscle can be affected later. The third form of very common in adults is the facioscapulohumeral muscular dystrophy that usually affect the facial and the ocular muscle and the upper girdle. So you can have specific muscle affected associated with non-specific myopathic muscle impairment, the neurophysiology. Laboratory tests show high CK level, but can be also normal. These are only three of the many forms in which a muscle disorder can present in patients. How do we reach a diagnosis in patients with muscle weakness and with distribution of weakness of the type we have seen in the previous slide? Well, certainly neurophysiology can be helpful by showing a myopathic pattern of the EMG. MRI can show some atrophic or fatty substitution in the muscle, so the muscles are weak because they are infiltrated by fatty, or they are losing the strength of the muscle and are replaced by connective tissue. But certainly the confirmatory diagnosis is reached by genetics. Everybody working with muscle patients and patients with inherited muscle disorders expect to reach a diagnosis for all patients. So there are multiple forms of testing, and we expect that one day we will have a diagnosis for everybody. But still, today in clinical practice, the diagnostic rate is about 1 in 2. We miss diagnosis in about 50%, 50% of our patients. How do we perform a diagnosis? Of course, combination of clinical data with family history and laboratory investigation may point to a specific clinical syndrome, for example, facioscapular muscular dystrophy, or for peripheral neuropathies to Charcot-Marie-Tooth type 1A. And so once you have this feeling, it's recommended a single gene testing. Other conditions present a certain specific family history and laboratory screening, but clinical presentation is more vague or more heterogeneous. So it's wiser to use a panel of genes associated with neuromuscular disorders. A panel of genes allow to reach a diagnosis in about 40-50% of the cases. But sometimes depends on how specific is the clinical presentation and whether there is a mixed pattern of myopathic and neurogenic patterns at investigation, neurophysiology investigation. Once you have performed a panel of genes, you may have not reached a diagnosis. You can move on to whole exome sequencing. Whole exome is offered by many diagnostic laboratories in Europe and is able to investigate the coding sequences of all the set of genes associated with the human disease. So you may find with whole exome also ultra rare etiologies and also different presentations in case of specific clinical syndrome. What is less common in diagnostic laboratories now, but maybe perhaps changing this in the coming years, is to offer whole genome sequencing. So the analysis of the entire DNA to patients in diagnostic setting. This is more at the research level now, but as the technology is improving, the cost per test are going down, it's possible that it's possible to transform our um, diagnostic approach from single gene testing to whole genome sequencing. We will see in the next 2 years. Regardless, you use all exome, all genome, single panel, regardless whether you see a duck or a rabbit here in your test, there is not always a easy corresponding between interpretation of data and reporting to patients. Interpretation of many variants in DNA are not easily transformed in a report to patients who has that specific clinical condition. So you may turn out to receive a diagnostic test where you have a set of positive variants, so-called mutation, or better to say pathogenic variant, that are a set of variants in your DNA. They may be associated for sure with a specific genetic condition. It may represent a diagnostic tool for your condition. Having a positive result is translated in a better option for management of your condition, and it also allows for family members to be tested for the same condition to identify healthy carriers or pre-symptomatic individuals. On the other side of the moon, you find the negative results where you have a test with no pathogenic changes identified. This does not exclude per se a genetic form, just saying that the number of tests you have done is not sufficiently robust to give you a diagnosis. And so your physician, your health provider may suggest additional testing. The more wide you go into gene testing, DNA testing, the more easy it is to find variant in DNA who are uncertain in their significance and are hard to be reported, if not to be interpreted. So I would say you have the white zone in the positive pathogenic variant, you have the black zone in the negative pathogenic changes, and so a large set of gray zone where a variant is detected, but it's not known to be disease-causing or benign. So in this case, your physician or your health provider may interpret this result as uncertain. So a result that cannot be per se sufficient to reach a diagnosis. Multiple tests are therefore necessary to make more robust a variant to uncertain significance, and the easy test is to analyze also family members for the same condition. Once you have reached a diagnosis or a potential diagnosis, you have always to consider that it's not so easy to take care once of your health once you have a neuromuscular disease. Neuromuscular diseases may affect the muscle for sure, may imply also involvement of other organs or other systems like a heart, or like the gastrointestinal tract, or may imply involvement of other expertise or specialties. So the important part is once you have a diagnosis of neuromuscular disorder, you and your family and your caregiver are should know that they are at the center of multidisciplinary team. Really, it takes a village to care for a patient with neuromuscular disorders. Also, in terms psychologists or occupational therapy or speech therapy, physical therapies, that's all important. And time to time, you need to reconsider the care. Perhaps at a certain period of this disease progression, it's more relevant to have a neurologist or a cardiologist. In other part of the progression of the disease, it's more relevant to be under the care of a pulmonologist or ENT doctor or people working with occupational therapy. Um, Once you have a diagnosis, for sure there are multiple feelings. Patients, especially parents, in case of young children, they are facing different feelings, like they feel scared about the future, they feel worried, if not shocked, because a diagnosis they would not expect. Um, so um, usually we should find a good balance between these patients' feelings and what we consider the combination of symptoms. What each specialty look precisely to symptoms related to their um, learned abilities, but we should have a look at the entire patient and combine this evaluation like a sort of case manager with what patients and families and caregiver experience. This is especially critical when the patient goes through a very long diagnostic journey. Going through this diagnostic journey, the patients may have several stop and go experience, hype and hopes, because, for example, a general practitioner suggests a new specialties, and the specialist suggests a new drug or a new treatment or a new test, and this test proves to be negative, so no diagnosis, and so time room for a new test, an additional expectation, additional hopes, and then positive results or negative results. And finally, after a long odyssey, you can be part of the group reaching a confirmatory diagnosis. So reaching a precise diagnosis is very important because has many consequences. It will shorten the diagnostic odyssey, alleviate the need for invasive and additional painful procedures like muscle biopsy in the diagnostic context, improve the psychology and the psychological impact for patients and family members by confirming the diagnosis and offering the opportunity for relative to be tested to know their carrier status. And also the mitigating the cost for preventing for unnecessary procedure and treatment. So making unnecessary tests not longer offered in once you have a diagnosis. As you heard before, CoMPaSS has the ambition to improve the diagnosis, expand the number up to 30% more, expand the number of patients who receive a full diagnosis. This may be possible with the use of artificial intelligence, in particular with a specific subset of artificial intelligence, the machine learning approach, by combining multiple sets of data and adopting tools of machine learning, we can devise, imagine potential new algorithms that allows a more easy diagnosis. In other words, CoMPaSS imagine as a dream of a world where you can revolutionize the diagnosis, management, and treatment of hereditary neuromuscular disorders. With this ambition, CoMPaSS expects to have impact on patients by reducing the uncertainty about their condition and having a way to stratify patients and direct them toward effective treatments. CoMPaSS has also the ambition to impact on specialists, on clinicians, by providing them with new tools to support the diagnosis of hereditary neuromuscular disorder, to choose the best test for the best patient at the best time, and also to harmonize the way they categorize patients and they speak about potato or potato. CoMPaSS has also the ambition to impact on scientific community by providing a set of data that can be extremely useful for research purposes and to promote additional activities in research laboratories to validate more and more the large set of variants of uncertain significance that we collect in diagnostic laboratories. Finally, CoMPaSS may impact also pharmaceutical company by producing information useful to develop new treatment, more effective to patients, and also health providers and a large set of stakeholders who might eventually imply a better health quality of patients and activities related to neuromuscular diseases. With this information and with our ambition, I thank you for your participation and I'm ready to take questions. Thank you.
Thank you very much, Filippo. Thank you for your presentation. And now we will follow the question and answer section.
Okay, question number 1. How can one participate in the study? There are multiple ways. If you are a physician, you can contact one of the clinical centers in CoMPaSS. If you are a patient, you can ask your physician to contact the coordinator, Professor Tupler, We had in multiple slides also a QR code that describe the procedure how to join CoMPaSS. What is important if you participate in the study, you have to sign an informed consent. You can offer to CoMPaSS the preliminary investigation you have been going through in the past years. You have to undergo a detailed clinical study, a MRI of the muscle, usually the legs, and eventually a muscle biopsy if not done before. The level of DNA studies allowed in CoMPaSS is very high level. It's at the genome level, so uh, much above what is offered in diagnostic laboratory. I don't know if Rossella want to add something to this.
No, I think that no, I think the patients can you explain perfectly. Um, it is possible to contact us with our names. Don't forget that there is the Munich Center also. So 2 centers in Italy and 1 center in Germany. So then we will take care, because now when people contact us, we explain everything, and then we examine them and we take care of the entire thing.
The second question is very challenging. What are the chances of improving the diagnosis? Okay. We have a very good ambition because we know that the power of machine learning and AI in healthcare is offering large opportunities. We know that if we collect precise data from clinical, morphological, imaging, and DNA levels, we have the chance to increase by 1/3 our diagnostic yield. Of course, we may collect a large number of information and need to understand what the different stratification, the different cluster of patients represents. But it possible is a completely different, I think, completely switch in diagnosis. As much as we work with rare conditions, we learn the the dogma of having one disease, one gene is no longer true. And we may expect now that one disease, one group of clinical manifestations is associated with a orogenic, a few set of genes. So if we switch our way of looking at patients, perhaps we improve the chance of diagnosis. And then we will have perhaps more diagnosis, mm, but we are positive for this.
Yeah, I can add, if I can add, I think what Filippo said, Professor Sartorelli said regarding the switch, this is very important, because probably we will must change our way of looking at disorders. And this, I am more positive about the outcomes, about our ability of treat diseases. So it is, we are really hoping to have a good change, a positive change.
How can AI help clinicians with diagnosis? Well, I'm not an expert of AI, but I know that one of the major trouble once you may reach a diagnosis and heterogeneity at the level of clinical and genetic features. So once you see a patient, the patient can have a combination of symptoms, a combination of weakness that do not fit exactly in one clinical category. On the other level, you may decide to run a test and genetic test, and you find multiple gene variants. Most of those are uncertain. In this specific point, AI can help us to discover the hidden part of the diagnosis. If AI can put together multiple information from different platforms, from different categories of omics, let's say, from clinical, combined with the MRI, combined with histology, combined also with the family history, and the genetics can be read in a different way. We know that the power of AI, because, for example, we can experience in a daily practice how AI can recognize immediately our face or our fingerprints when we activate our mobile phone. We expect that AI works in a clinical setting much stronger than this, and uh, can allow us to see from a foggy set of data, what appear to be a foggy set of data, precise diagnosis. Again, we are positive on that.
Thank you.
Another question is from the audience is, can CoMPaSS improve how patients are cared for? I would say yes. More precise diagnosis, more rapid diagnosis, more precise stratification of patients will allow caring of the patients more rapidly, investigate better the many comorbidities that we are expecting in that specific disease, and stratify the needs for individual patients, so finding commonalities from multiple patients just to offer the best care. At the same time, data from CoMPaSS are likely to promote further research in the mechanism, but also in developing new drugs. So once we have a new drug, we have more precise population of patients where that drug will be likely working. And altogether, these represent a plus for patients and for the family. What are the inclusion criteria for the study? Well, the major criteria is to have an inherited neuromuscular condition, so to be affected by a neuromuscular disorder is a major criteria, and to sign a informed consent to the study, and to have excluded other secondary form like toxic or inflammatory diseases affecting the muscle. Any age can be included. We have centers recruiting children, adults, patients with who are sporadic, patients who are part of a large families, all are welcome to join CoMPaSS.
No more question, I think. Probably we can close. And the next appointment should be in the next slide, if I am correct. I hope everything was clear, and I hope you enjoy. I hope you know more and you like a CoMPaSS-NMD. And the next slide, the next appointment is October 20th. And we will have the Professor Polanska who will explain more things about artificial intelligence. So Professor Polanska is an expert, is our partner who prepared the new algorithm, and we will go straight to the point, straight to the heart of the CoMPaSS. And we will wait for the final greetings, and see you next time. Thank you very much. Thank you
for listening.
Thank you. Bye. Bye.
Nice rest of the day.